The puerperium is the clinical 6-week period immediately following the delivery of the placenta. During this window, the profound anatomic changes induced by pregnancy have to dismantle themselves and return to a non-pregnant baseline. This systemic reversal is triggered by an endocrine crash. The moment the placenta is delivered, its hormone production stops. This chart tracks that drop. We can see the levels of human placental lactogen and beta-HCG plummeting from their peak, becoming completely undetectable by day 10. Maternal hormones follow the exact same pattern. Notice these two new lines for estrogen and progesterone. They crash as well, stabilizing at their low pre-pregnancy baseline by day 7. This rapid systemic dismantling leaves the mother in a state of extreme physiological vulnerability. It sets the stage for the postpartum triad, the 3 primary drivers of postpartum morbidity and mortality. These are secondary postpartum hemorrhage, followed by venous thromboembolism, and finally, puerperal pyrexia. Successful clinical management of the puerperium requires mapping the normal timeline of this systemic involution against the specific onset windows for these 3 pathologies. To understand the scale of this involution, we start with the genital tract, specifically the uterus after the 3rd stage of labor. Looking at this 3D cross-section of the female pelvis, watch the uterus. Over a 7-day timeline, its weight drops by half, falling from 1,000 to 500 grams. By the 2-week mark, it recedes entirely below the pelvic brim, no longer palpable abdominally. The cervix undergoes a parallel constriction. For the first 4 to 6 days, it admits 2 to 3 fingers, but by days 10 to 14, it closes to barely more than 1 centimeter. The direct byproduct of this rapid uterine shrinkage is lochia, sloughed-off necrotic tissue mixed with blood. This timeline highlights the chronological progression of lochia over 3 to 6 weeks. It begins as lochia rubra, a red discharge, before shifting to a paler lochia serosa, and finally resolving as a yellowish-white lochia alba. This predictable shedding process must be carefully distinguished from our first pathology, secondary postpartum hemorrhage. Secondary PPH is strictly defined as any abnormal bleeding that occurs between 24 hours and 6 weeks postnatally. The primary anatomical causes for this bleeding are retained products of conception, an infection like endometritis, or an undiagnosed genital tear. The clinical severity of this condition is high. It remains a major cause of maternal death in developing nations. Even in developed countries, 2% of postpartum women are readmitted for this hemorrhage, and 50% of those admissions require surgical evacuation. Clinicians must continuously differentiate expected necrotic shedding from pathological bleeding. Failing to recognize this transition can quickly put a patient on the operating table. Immediately following the delivery of the placenta, the focus shifts from the pelvis to the systemic cardiovascular system. There is an immediate, transient spike in cardiac output, caused by a sudden volume of blood returning to systemic circulation from the contracted uterus. On this dual-axis chart, maternal plasma volume drops by 40% on one axis. On the inverse, fluid excretion, or diuresis, spikes sharply over a 2 to 3 week timeline. By excreting extracellular fluid, maternal blood volume normalizes by day 21. This brings us to our second pathology, venous thromboembolism. The combination of rapid fluid reduction, vascular trauma from birth, and physiological venous stasis creates a dangerous environment for blood clotting. The stakes are severe. VTE is the second major cause of direct maternal death in the UK. This requires strict vigilance for the clinical signs of deep vein thrombosis. These include swelling, erythema, lower abdominal pain, and specifically unilateral leg pain, most often presenting in the left leg. If a clot travels, it progresses to a pulmonary embolism, marked by dyspnea, focal chest signs, hemoptysis, and sudden collapse. Any suspicion of these symptoms demands an urgent investigation protocol, starting immediately with pulse oximetry, an ECG, and a chest X-ray. The body's mandatory requirement to drastically reduce its fluid volume inherently sets the stage for lethal vascular complications. There is zero clinical tolerance for ignoring leg or chest pain during this window. The final component of the triad is puerperal pyrexia, which historically stood as the most common cause of maternal mortality prior to the introduction of sulfonamides in the 1930s. The absolute clinical metric for this pathology is the presence of a maternal fever of 38 degrees Celsius or higher within the first 14 days after giving birth. Isolating the fever's cause requires a strict differential diagnosis. We map this using a decision tree for the first 14 days, splitting into genital and non-genital causes. Looking at the genital branch, the prominent concerns are uterine infection, specifically endometritis, and perineal wound infections. Endometritis is heavily predisposed by prolonged labor, intrapartum chorioamnionitis, and cesarean sections performed without prophylactic antibiotics. It presents clinically with foul-smelling lochia, subinvolution, and a tender, bulky uterus found on abdominal examination. If those signs are absent, the investigation shifts to the non-genital branch, focusing on nodes for breast, urinary tract, respiratory, and abdominal wound complications. Breast engorgement alone causes high fevers, sometimes reaching 39 degrees Celsius, in 15% of women, requiring careful differentiation from infectious mastitis or abscesses. Other non-genital vectors include urinary tract infections stemming from a hypotonic bladder and respiratory atelectasis, which is frequently seen in the first 24 hours post-cesarean. Once the source of the infection is identified, management requires aggressive pharmacological intervention, prioritizing broad-spectrum coverage against anaerobic bacteria. Protocols dictate a combination of clindamycin and an annamycinicide like gentamicin for endometritis, while preventing the infection entirely requires cefuroxime prior to skin incision for cesarean prophylaxis. Accurate mapping of the pyrexia differential dictates the exact survival pathway. It is the only way to separate easily managed breast engorgement from lethal systemic pelvic sepsis. Before a patient is discharged, routine care requires establishing physical baselines, such as checking the maternal hematocrit level and administering the RhoGAM vaccine for Rh-negative mothers. Standard physical recovery also demands symptom management, utilizing NSAIDs for painful uterine contractions and transition therapies, like moving from ice to warm sitz baths for perineal trauma. Additionally, bladder hypotonia and voiding difficulties require close monitoring, sometimes mandating catheterization to prevent tissue damage from overdistension. Clinical teams are highly trained to monitor these physical markers of hemorrhage and sepsis, but the puerperium contains a severe psychiatric blind spot. Mental illness is a leading cause of maternal death, primarily driven by suicide associated with perinatal depression. This timeline reveals the true scope of the danger. While the standard puerperium is mapped out over 6 weeks, the psychiatric risk window extends much further, stretching from 6 weeks prenatally all the way to 12 weeks postnatally, where over half of these suicides occur. These occurrences are sudden and violent, disproportionately affecting the 7 to 30% of women who lack adequate psychological support in developed nations. Safe discharge from the puerperium requires both physiological clearance and an ongoing safety net for psychiatric emergencies, a protection that must remain active long after the traditional 6-week window closes.